So let us start with regional anesthesia. Guys, if there are 10 questions from anesthesia, now 7 are from general anesthesia and 3 are from regional anesthesia, maybe 1 or 2 questions from miscellaneous topic. But PGI entrance exam, if there are 10 questions from anesthesia, 5 from general and 5 from regional anesthesia. A lot of questions are asked from regional anesthesia and PGI entrance exam. Important but a very small topic. Just 2 things we have to study in regional anesthesia. Now if I ask you, give me the examples of regional anesthesia, what examples will you give me? You will say spinal anesthesia, epidural anesthesia, you will say brachial plexus block, sciatic, femoral. If we go on saying the name of regional anesthesia, the different ways in which we give regional anesthesia, I can go on saying it for hours. You getting my point? There are so many ways of giving regional anesthesia, right? But in every regional anesthesia, we do the same thing. What? We deposit the drug near the nerve fibers we want to block. If I want to block brachial plexus, I deposit the drug near brachial plexus. If I want to block spinal nerve, I deposit the drug near spinal nerve. If I block femoral nerve, I put the drug near femoral nerve locally. We are putting the drug locally near the nerve we want to block. And what is the drug doing? It is reversibly stopping the sensory, motor and autonomic outflow of the nerve fiber, and the area supplied by nerve fiber gets anesthetized. This is what is regional anesthesia, right? In this we have to discuss 2 topics. The drug responsible for producing this regional anesthesia, that is local anesthetic. And second, we have to discuss something called central neuraxial blockade. Central neuraxial blockade. Okay? Something called central neuraxial blockade. Got it? Okay? Now see on the screen, what is the central neuraxial blockade? Now this is your, let's say, this is your spinal cord. From spinal cord, 31 paraspinal nerves come, right? If I block these spinal nerve, right? They come under central neuraxial blockade, that is spinal and epidural. If I block brachial plexus, femoral, sciatic, they come under peripheral nerve blocks. Got it? So regional anesthesia is basically divided into central neuraxial blockade and peripheral nerve blocks. Okay? And we have to discuss central neuraxial blockade, in which we have to discuss 4 important topics. We have to discuss the difference between spinal and epidural, complications of spinal and epidural, contraindications of spinal and epidural, and central neuraxial analgesia, not anesthesia, in which I will discuss with you labor analgesia and post-op analgesia. So these are very important topics which we have to discuss in central neuraxial blockade. But before that, let us discuss few things about local anesthetic, the drug responsible for regional anesthesia. Okay, so let us talk about something called local anesthetic. Let us talk about local anesthetic. Okay. What is this local anesthetics? As the name says, local anesthetic. Remember, we always give it locally. We never give it intravenously. Right? Let me tell you the definition of LA. Need not copy, need not write. Just listen. Local anesthetics are those drugs which reversibly block sensory, motor and autonomic outflow of a nerve fiber. Got it? Now first point of local anesthetic. Now this is the nerve fiber, I want to block it. Got it? This is the nerve fiber, I want to block it. How do I block it? I put the local anesthetic near this nerve fiber. This could be any nerve fiber. This could be femoral nerve, this could be sciatic nerve, this could be brachial plexus, any nerve. If I block it, if I have to block it, I put the drug around it. Where does the drug act? How does the transmission of this nerve fiber is blocked? Guys, there are so many voltage gated channel on the nerve fibers. Sodium channel, chloride channel, potassium channel, so many channels. Local anesthetic primarily blocks the sodium channel. So, sodium channel blocked by local anesthetic, right? Sodium channel is blocked by local anesthetics. For local anesthetic, I may write LA. Okay. Okay. Now guys, apart from sodium channel, which is primarily blocked, what happens? Local anesthetic binds to this sodium channel, stops the depolarization of the sodium channel, and prevents the propagation of nerve impulse. Got it? But beside sodium channel, local anesthetic can also have an effect on potassium, calcium, and NMDA channel. Right? The positive channels. So it has an effect on potassium, calcium, and NMDA channel. Got it? So beside sodium channel, local anesthetic has effect on 3 more channels: potassium, calcium, and NMDA channel. Got it, everyone? But primarily it blocks sodium channel. So if a question of AIMS is asked, which of the following channel is affected by local anesthetic? Sodium, potassium, calcium, NMDA. Answer would be sodium, primarily sodium. If a question in PGA asked, which of the following channels are affected by local anesthetic? Sodium, potassium, calcium, NMDA. Answer could be all. So little bit effect on potassium and calcium and NMDA channels as well. Okay. Now second point. These are the sodium channel present on the nerve fiber. These are the sodium channel present on the nerve fiber, right? Right? How do I block it? I put the drug, local anesthetic, around this nerve fiber, right? The attachment of local anesthetic on the sodium channel is not on its outer surface, but on its inner surface. That is, on its cytoplasmic side. Okay. Now let's say the sodium channel. These nerve fibers are in 3 states: active, inactive, and resting. When the nerve fiber is in active stage, sodium channel is wide open. When in inactive and resting, sodium channel is tightly closed. If I put drug, local anesthetic, near an active nerve fiber, very easily it goes inside and bind to the sodium channel from its inner surface. If I put the drug near inactive or resting fibers, it will block the sodium channel by diffusing across the membrane of the nerve fiber. But this would take some time. Well, if you have to enter a house, gate is open, you enter easily. But if gate is closed and you have to enter it, you climb the boundary and jump inside. The similar is the case. When the gate is open, I get the block fast, and when the gate is closed, I get a block slow. So remember, action of local anesthetic is best when the nerve fiber is in its active state. So when the nerve fiber is in its active state, action of local anesthetic is best. Based on first and second point, that is, it acts on sodium channel and acts on active nerve fiber best. It acts on sodium channel, which is a voltage gated channel, and acts best when the sodium channel is open, that is, when its nerve fiber is in active state. Based on these 2 points, a question is asked in PGI. Action of local anesthetic, voltage gated, time gated, both voltage and time gated, none of the above. Answer is always both voltage and time gated. It depends upon the voltage, and it is also dependent upon the time when you have put the drug, right? So third point, action of local anesthetic is both voltage gated and time gated. So action of local anesthetic is both voltage gated and time gated. Got it? Okay. Now fourth point. Guys, this is the nerve fiber with sodium channel present on it, and I have to block this nerve fiber, and we have deposited drug near this nerve fiber. Now, is it possible in the body where there are nerve fibers, there are only nerve fibers and no blood vessels? No, not possible. We have network of blood vessels. Got it? Around the nerve fibers, arterial, venous, both. right? So we have network of blood vessels. Getting my point? If this local anesthetic gets absorbed in surrounding blood vessels, what will happen? What does local anesthetic needs? Sodium channel. And sodium channels are located everywhere in the body. It is located everywhere in the body, on brain, on heart, everywhere. So what will happen? It will block those sodium channel of brain and heart and will cause systemic toxicity. So let us assume I am using 20 ml 0.25% bupivacaine, right, for brachial plexus block, right? I am giving this much drug for brachial plexus block. What happens? Of this, 10 ml got intravascularly absorbed and 10 ml remain there for the action. The 10 ml which remained there locally for the action produced the onset of block within 45 minutes and duration for, let's say, 1.5 hours. Okay? But let's say with 20 ml 0.25% bupivacaine, I add something called a vasoconstrictor. I add something called vasoconstrictor, like adrenaline, phenylephrine, any vasoconstrictor. What will happen? It will constrict the surrounding blood vessel. What will happen? Let's say 2 ml drug now intravascularly absorbed, 18 ml there for the action. Now the onset of block in 5 minutes and duration for 3 hours. So what is the benefit of adding this vasoconstrictor? First, less drug was systemically absorbed, so less chance of systemic toxicity. Second, this was the first benefit. Second, onset of block which took 45 minutes, it turned into 5 minutes. So fast onset. Duration got prolonged. Third benefit. And since there were more drug for the action, intensity became better of the block. But one major problem. Whenever you put a local anesthetic along with vasoconstrictor, or rather, whenever you put a vasoconstrictor anywhere, it would cause vasoconstriction. That's why we are giving it, of course. But since it is causing vasoconstriction, little bit ischemia of the area, little ischemia and release of inflammatory mediator, the site becomes very painful because of the release of this inflammatory mediator. Patient may complain, "Doctor, you wanted to block this limb of mine, that is left upper limb, it is blocked. I cannot feel anything." But the point where you have put the drug, it's paining very badly. So it increases pain on injection, right? And one more problem, this combination is contraindicated for the site where end arteries are located, like your finger block, your toe block, etc. Why? Vasoconstrictions of end arteries, ischemia and gangrene would result. Got it? So what is the advantage and disadvantage of adding vasoconstrictor? Advantage and disadvantage of local anesthetic plus vasoconstrictor. Vasoconstrictor. Okay? Advantage number 1. Decreased systemic toxicity. Okay? Then decreased onset time. Then increased duration. Then better intensity of the block. Okay? And what is the disadvantage? Increased pain at the site of injection and contraindicated for the sites where end arteries are located. End arteries located. Got it? So it's contraindicated for finger block, contraindicated for toe block, all these conditions. So it's contraindicated for the sites where end arteries are located. So this is a disadvantage of putting vasoconstrictor with local anesthetic. Guys, I want the benefits, but I don't want this pain. Right? Patient is conscious. If patient is feeling pain at the site, there would be problem. So nowadays we don't add vasoconstrictor. We add something else to the local anesthetic. And what is that? See, this is the nerve fiber I want to block. Okay. So whenever I have to block this nerve fiber, I put the drug around this nerve fiber, Okay. What happens? What happens when you put the drug around this nerve fiber? Well, guys, all drug has its own pK, the dissociation constant of the drug, the pH at which it dissociates, right? And the area has its own pH, the area where I am depositing local anesthetic. Now, you know, pK of the dissociation constant of local anesthetic, most of them, is from 7.5 to 8.2. That is, it's more alkaline side. Area has its own pH. It will never match. So what happens? Whenever you put a local anesthetic anywhere near a nerve fiber, since the pH and pK value of local anesthetic does not match, to reach an equilibrium, some of the drug dissociate, that is ionized, and the some remains undissociated. Okay? The drug which is dissociated, it is wasted. Why? Because this cannot bind to the sodium channel, the dissociated drug. Okay? The drug which is undissociated can only bind to the sodium channel. Got my point? So dissociation was wasting the drug. Now, since the pK value of La is near alkaline pH, alkaline site, so what we do, along with, this is the nerve fiber I have to block. I put the local anesthetic around it. Along with it, we add something called sodium bicarbonate and keep the pH of the area alkaline. Keep it near the pK of local anesthetic. What happens? Local anesthetic dissociation, right, decreases. Undissociated drug, more. So better action. You know, whenever we give regional anesthesia near infected site, which is obviously acidic, the block is not very good. So if I keep the site where I am depositing the drug alkaline site, basic site, the action of the drug would get better. And remember, acidity increases pain, alkalinity decreases pain. So this addition of sodium bicarbonate was giving us an added advantage of less pain at the site of injection. Got it? So what is the advantage of adding? Advantage of adding sodium bicarbonate to local anesthetic. Since more drug was undissociated, onset fast, duration prolonged, intensity better, intensity of the block better, and decreased pain on injection. Decreased pain on injection. Got it? These are the benefit of adding sodium bicarbonate to local anesthetic. Got it? Okay. Now, fifth point. There are how many types of nerve fibers? Grossly, the nerve fibers are of three types: A, B, and C. For the C carry pain and post-ganglionic sympathetic fibers. Sympathetic fibers. What does B carry? Pre-ganglionic autonomic fibers. right? What does A carry? A alpha, beta, gamma, delta. Guys, sensory to motor fibers. Now, I have given it very crudely. You have to memorize it precisely from any physiology book. My concern is only this much, that local anesthetic is most sensitive on which nerve fiber. Local anesthetic is most sensitive on which nerve fiber. Which nerve fibers is blocked fastest? B fibers most sensitive to least sensitive. Right? We are going most sensitive to least sensitive. Okay. B fibers most sensitive to the effect of local anesthetic, then C, then A. Now you may find it is written in some books C fibers, then B fibers and then A fibers. Actually, that was a thing of past. The recent studies and recent research has shown, and clinically also we see that B fibers are blocked first. This is according to the fibers. According to the transmission, which transmission is blocked first? Autonomic, sensory and motor. So autonomic transmission is blocked first, then sensory and then motor. This is according to the transmission. According to the sensation, which sensation is blocked first? Well, if you have seen anyone giving regional anesthesia, you may have noticed. How do we check the block for the appearance of block? Well, if I have given right brachial plexus block and I'm expecting this limb to get anesthetized of the patient, how do I check it? I take a spirit swab and start touching the skin of the patient and ask the patient, are you feeling cold? Are you feeling cold? Temperature goes first, and that too cold. If patient stops feeling cold, then I pick up a pen and start pricking the patient. Are you feeling pain? Guys, number of time patient says, doctor, you are pricking me, I can feel it, right? Pain sensation has yet not gone. So if, let's say, patient doesn't feel the pain of pricking, pain gone. Number of time patient says, doctor, you are touching me, I can feel it, but I cannot feel any pain. Touch goes very late. Number of times touch remains and we get the surgery done because pain has gone. And then goes proprioception. So, first temperature, that too cold. Then your pain, then touch, and then proprioception. Okay, now very important guys, please see on the screen. This question was asked in GPMR that when the nerve fibers are recovering from the effect of local anesthetic, what is the sequence? Opposite. Opposite to the sequence in which they are getting blocked. Now, A fibers are least sensitive. So, when the concentration of local anesthetic starts decreasing, the A fibers recovers fastest. Got it? So, recovery is in the opposite direction. So, you can write it. Recovery from the block, recovery from block is in opposite direction. Opposite direction. Got it, everyone? So this is the sequence of block and recovery. Now, if I ask you, give me example of any LA. Well, let's say I pick up bupivacaine. Let's say I am using bupivacaine for a block, and I am giving 0.5% bupivacaine. This concentration of bupivacaine is enough to block autonomic fibers of a nerve fiber, sensory fibers and motor fibers. Got it? But if I reduce the concentration of bupivacaine from 0.5 to 0.25%, okay, then autonomic and sensory fibers are blocked and motor is spared. What have we written? Motor fibers are least sensitive. Got it? Least sensitive. What they need? They need a higher concentration. By decreasing the concentration, I can spare the motor fiber and can produce something called differential block. What is this differential block? Differential block. Differential block is blocking sensory, sparing motor. Okay? Blocking sensory, sparing motor. Now, where do we use it? Well, the most common place where we use it is painless labor. For labor analgesia, Patient can push the baby but cannot feel the pain because we have blocked the pain fibers and left the motor fibers intact. Post-op analgesia. Patient can ambulate but cannot feel the pain because we have blocked the pain fibers. So this is what is differential block. Blocking sensory, sparing motor. Got it? Now coming on the 6th point. There's so many ways I can give regional anesthesia. Paravertebral, paracervical, caudal, lumbar, epidural, brachial plexus, sciatic, femoral. There's a question asked in exam. Fastest systemic absorption of local anesthetic takes place by which route of regional anesthesia? Definitely it depends upon what? It depends upon the vascularity of the area. So, if the area where I am putting the drug for the block is very vascular, the chances of intravascular absorption is very high. For example, if I have to block intercostal nerve, how do I block it? I have to put the drug near intercostal nerve. Then only it will get blocked. But where I put a drug for the intercostal nerve block, the intercostal artery and vein is adjacent to intercostal nerve. They all are present together in neurovascular bundle. So if I have to block this nerve, artery and vein is beside the nerve. So what will happen? The drug can get intravascularly absorbed. The chances of systemic toxicity becomes very high. There's a sequence of systemic absorption of local anesthetic which we have to remember. Systemic absorption of local anesthetic. Systemic absorption of local anesthetic. Okay. Hypothetically, I am writing IV. We never give it IV. By mistake, I gave the drug IV. So everything was systemically absorbed. So IV. After IV, the fastest systemic absorption, tracheal. Guys, trachea is covered by mucosa and mucosa is richly supplied by blood vessels. Chances of systemic absorption is very high. You know, in CPCR, if I am unable to put an IV line, 2 to 2.5 times the IV dose of the drug, emergency drug we give through intratracheal, and it gets absorbed very nicely. So trachea is very vascular. Then intercostal block. The intercostal block. Then paracervical block. Then caudal. Then lumbar epidural. Then brachial plexus. Then sciatic, and then subcutaneous, right? IV, tracheal, intercostal block, then paracervical, then caudal, then lumbar epidural, and brachial plexus, sciatic, subcutaneous. This is a sequence of systemic absorption. Fastest, of course, IV, then tracheal, then intercostal, then paracervical, then caudal, then lumbar epidural, brachial plexus, sciatic, subcutaneous. Okay. Now coming on the 7th point of local anesthetic. Local anesthetic has aromatic group and has a amino group attached to each other by a ester bond, right? Either ester bond or by a amide bond, right? By a amide bond. Got it? So depending upon this, the local anesthetic is divided into two groups: amino ester, amino amide. So local anesthetic is divided into two groups: ester and amide. Got it? What bond attaches aromatic group to amino group, right? Either ester or amide. Depending upon it, it is divided into two groups, ester and amide. And guys, what are the drugs which comes in these two groups? In ester we have cocaine, procaine, chloroprocaine, benzocaine, tetracaine, right? In amide we have lignocaine, mepivacaine, prilocaine, bupivacaine, ropivacaine, bupivacaine. First three drug of both of ester group short acting, last two long acting. Amide, first three drug intermediate acting and last three long acting. This is according to the duration of action, right? Short acting, intermediate acting, long acting. Now guys, I have to discuss with you these drugs. There are some common points which I need to tell you, and unique points I would go on adding in the table itself. Okay. Now all ester LA except cocaine is metabolized by pseudocholinesterase. Is metabolized by pseudocholinesterase. Guys, I talked about pseudocholinesterase, that it metabolizes succinylcholine, imivacurium, and now ester local anesthetic except cocaine. Okay? Cocaine and amide metabolized by liver. Metabolized by liver, hepatic metabolism. Got it? Okay. Drugs metabolized by pseudocholinesterase produces a byproduct, PABA, para amino benzoic acid. That is PABA. This PABA causes allergy. PABA causes allergy. So they produce PABA and PABA causes allergy. No PABA, no allergy. No allergy. So ester LA metabolized by pseudocholinesterase are notorious in causing allergy. That's why guys, nowadays ester local anesthetic not much in clinical use. What we are using? Amide local anesthetic. Mostly we are using amide local anesthetic. Okay. So let us discuss few extra points about every drug. But before I discuss anything about it, just let me tell you a few things about how do we give local anesthetic. See, we are using amide more commonly. Amide are metabolized by liver. In case of any liver derangement, right? Liver function deranged, we use lesser dose of local anesthetic because metabolism would get delayed. Okay? Local anesthetic needs to be given very carefully because of the risk of systemic toxicity if not metabolized or something like that. Similarly, in a patient with shock, patient is in shock, right? Whenever someone is in shock, there is a preferential perfusion of the vital organs. So most of the bloods are directed towards brain and heart. So if I give a usual dose of local anesthetic to a patient in shock, whatever intravascular it is getting absorbed, little bit always will get absorbed, would straight away go to heart and brain. So more chance of systemic toxicity. So in case of a patient in shock, in case of a patient with deranged liver function, we use lesser than normal dose. Lesser than normal dose of local anesthetic for any block. Got it? Okay. Now let us start with the first drug, that is cocaine. What are the points of cocaine clear from the chart? It is short acting, it is ester, and it is exception in this group, being metabolized by liver and causing no allergy. Right? What extra point we need to talk about cocaine? Guys, cocaine is a coca plant extract. It's a natural LA and first LA to be used clinically. So this is first local anesthetic to be used. It was first time used for ocular surgery. It's a natural LA, only natural LA. Okay, and it is metabolized by liver. First exception, which we have already written, and this is the only LA which is vasoconstrictor. All local anesthetic are vasodilator. Cocaine is a vasoconstrictor. What does cocaine do? It constricts the surrounding blood vessels. So what happens? Right? This causes vasoconstriction, less systemic absorption with cocaine. Got it? Guys, why is cocaine vasoconstrictor? Simple. Why is any drug vasoconstrictor? It's sympathomimetic. Cocaine is also sympathomimetic. So cocaine is sympathomimetic. Got it? Okay. So this is all about cocaine. Next is procaine. Short acting ester pseudocholinesterase allergic reaction. Nothing else. Chloroprocaine. Short acting ester pseudocholinesterase allergic reaction. One extra point. These three all are short acting, but chloroprocaine is shortest acting. Shortest acting. So chloroprocaine is shortest acting. Got it? Since chloroprocaine is shortest acting, it is one of the most used LA for daycare surgeries. Right? So for daycare surgeries, chloroprocaine is most commonly used. Most commonly used. Okay? Fine. Now, next is benzocaine. Long-acting ester pseudocholinesterase and allergic reaction. Common points clear? One extra point. See this whole group of LA, and in this benzocaine and this prilocaine produces a common side effect. What is that? They produce a common side effect. They produce something called methemoglobinemia. Right? They cause something called methemoglobinemia. What is methemoglobinemia? The hemoglobin, the iron is in ferrous state. If it is oxidized to ferric, it's called methemoglobin. So, benzocaine, prilocaine, and a combination LA, EMLA. Combination LA, EMLA. Which I would discuss. Mixture of two local anesthetic, prilo and ligno. So because of prilocaine, this can cause methemoglobinemia, right? Let's say nitrobenzene compounds can cause methemoglobinemia, etc. These three local anesthetic can cause methemoglobinemia, which is being asked in exam. So we have to keep it in mind. Okay. Now, tetracaine, long-acting ester pseudocholinesterase allergic reaction. Nothing else. Ester LA, not much in clinical use. They cause allergic reaction. Amide LA is more commonly in clinical use, and in little detail we have to discuss. But before I discuss any amide LA, let us discuss a very important thing, something called LAST. What is this LAST? What is this LAST? Full form of LAST is local anesthetic systemic toxicity. Local anesthetic systemic toxicity. Well guys, if you have seen anyone giving regional block, you may notice that before giving the drug, let's say if I have to give brachial plexus block, I locate the brachial plexus by any technique I want to locate, ultrasound guided or C-arm guided or anything. But before giving the drug, I always aspirate and check. Check that the needle is not touching any vascular structure. Got it, everyone? Why? Because if I put the drug intravascularly, what will happen? It will cause systemic toxicity. Got it? Let us say I didn't check or my needle later on moved, and when I was giving the drug, patient suddenly says, Doctor, I'm not feeling well. Apprehension. Doctor, something is ringing in my ears. Tinnitus. I cannot feel anything around my lips. Perioral numbness. Suddenly something like this starts. That is perioral twitches and seizure. The drug is not getting deposited locally. It is getting systemically absorbed, and it is causing CNS toxicity. Local anesthetic systemic toxicity needs to be discussed in two headings. CNS toxicity and CVS toxicity. What are the clinical features of CNS toxicity? Just now I wrote apprehension, right? Apprehension. Okay. Apprehension. Then perioral numbness. Perioral numbness, right? Then tinnitus, then perioral twitches and seizure. Okay. So these are the features of CNS toxicity. Tell me, any of these features life-threatening? No, none of them, not even seizure. I can manage them easily. Being an anesthetist, I would give anesthetic agents. It will immediately stop it if other routine anti-epileptic will not work. None of them is life-threatening. More drug was systemically absorbed and now it went and blocked the sodium channel of heart. CVS toxicity. What will happen? Arrhythmia, cardiac arrest. Arrhythmia, cardiac arrest. Right? What will happen? Cardiac arrest, life-threatening. I do not fear CNS toxicity. I dread CVS toxicity. Got my point? I do not fear CNS toxicity. I dread CVS toxicity. Okay? For every drug, it is calculated. Dose at which it causes CNS toxicity and dose at which it causes CVS toxicity. Drugs with a wider margin between two are considered safer local anesthetic. Right? Let us assume I have two drugs. Drug A, drug B. Drug A is causing CNS toxicity at, let's say, 200 milligram and CVS toxicity, let's say, at 1400 milligram. Right? Drug B is causing CNS toxicity at 250 milligram and CVS toxicity, let's say, at 500 milligram. Which is the safer drug? Definitely drug A with a wider margin between CNS and CVS toxicity. For every local anesthetic, it is calculated CC-CNS ratio. That is, dose at which it causes cardiovascular toxicity, dose at which it causes CNS toxicity. Higher the CC-CNS ratio, safer the drug. So for A, this ratio is 7 and for B, this ratio is 2. So definitely A is a better drug. And this best drug with the highest CC-CNS ratio is our lignocaine, safest local anesthetic, the only LA which can be given IV as antiarrhythmic, right? And this drug with very less CC-CNS ratio, low CC-CNS ratio, is our bupivacaine, which is considered as most cardiotoxic local anesthetic. Most cardiotoxic local anesthetic. So bupivacaine, most cardiotoxic, lignocaine, most safest. Got my point? Now, how do I manage this systemic toxicity? How do I manage? Management of this last. Guys, symptomatic. All the features according to the rule. If my patient is complaining, apprehension, I reassure the patient. Perioral numbness, I reassure the patient. Tinnitus, I sedate the patient. Perioral twitches, I reassure or sedate the patient. Seizure, I give anti-seizure medication. Arrhythmia, depending upon the type of arrhythmia I manage. Cardiac arrest, I do CPCR. Got it? Any cardiac arrest, we do cardiopulmonary cerebral resuscitation. Similarly, we do CPCR. So symptomatic management. Whatever the symptom, we manage it. And one additional drug. Whenever we suspect local anesthetic toxicity, we give 20% intralipid emulsion. 20% intralipid emulsion. What will it do? This 20% intralipid emulsion will cause lipid escape of local anesthetic. It will absorb the local anesthetic and cause its let's say, it will take it away from sodium channel. This is considered as antidote in local anesthetic systemic toxicity. 20% intralipid emulsion infusion we start. Right? So this is one special drug for managing LAST. Got it? This is all about LAST. Now let us come on individual drugs. The first LA, amide LA, which I want to discuss with you is lignocaine. Now what are the points which you know about lignocaine? You know about lignocaine? It is intermediate acting. It is amide LA, right? Then we know it is metabolized by liver, hepatic metabolism. Then we know that no allergy, no allergy, right? Associated with it. Then we know safest local anesthetic. Guys, safest LA, the only LA which can be given intravenously, we discussed. And this is local anesthetic of choice. Choice for IVRA. What is this IVRA? Intravenous regional anesthesia. Intravenous regional anesthesia. Or we call it Byers block. Or we call it Byers block. Intravenous regional anesthesia, or we call it Byers block. What is this intravenous regional anesthesia? It seems very contradictory. How do we give regional anesthesia? We give it locally. We don't give it intravenously. So what is this IVRA? Well, it is given in extremities, either upper or lower. Let us say I have to give IVRA of my right upper limb. I have a right trigger finger developed in my patient of right upper limb, and I have to give right IVRA, right upper limb IVRA, and get it released, tendon release. So what do? I tie to tunicate in this upper limb, right? I tie to tunicate and inflate the tunicate, double the blood pressure of the patient, and cut this limb from rest of the circulation, right? Then I put a IV cannula in this limb, and through this IV cannula, I give the anesthetic agent intravenously. It remains in this limb, doesn't go in the systemic circulation, and all the nerve fiber of this limb gets anesthetized. So I am getting a regional block through IV route, we call it IVRA. But if this tunicate loosens, the drug can go in the systemic circulation. My bad luck, it opens, all drug will go in systemic circulation. So there is a let's say risk of systemic toxicity associated with it. So safest LA is local anesthetic of choice, and unsafest LA is contraindicated. So what is contraindicated? I know you must be knowing the answer, bupivacaine. So for IVRA, contraindication is bupivacaine. Okay? So bupivacaine is contraindicated for IVRA. Got my point? Okay. Guys, we tie tunicate in normal people. If we tie tunicate for upper limb for 1.5 to 2 hours and lower limb 2.5 to 3 hours, there won't be any ischemia, etc. But in some patients with diseases like peripheral vascular disease, sickle cell anemia, the tunicate cannot be tied for that long. So there are few contraindications of IVRA, which we have to know. Contraindication of IVRA. Number 1, sickle cell disease. Number 2, peripheral vascular disease. Number 3, scleroderma. These are absolute contraindication of giving IVRA. Got it? Asked in exam. Guys, local anesthetic, I told you, is associated with systemic toxicity, can be associated with systemic toxicity. So for every local anesthetic, there is an upper limit beyond which we cannot use it even locally. And you have to memorize the maximum safest limit of lignocaine with adrenaline we can use for a block, and alone we can use for a block. It's very commonly asked in exam. Okay, so what is maximum safest dose of lignocaine plus adrenaline for block? It is 7 milligram per kg body weight. Okay, alone it is 3 milligram per kg body weight. Very important for exam point of view, and we have to discuss. Okay, we have to memorize. For example, a patient was given a peribulbar block for cataract surgery. Surgeon was using the lignocaine plus adrenaline. What is the maximum dose he can give? 7 milligram per kg body weight. Got it? So this is all about lignocaine. What is the next drug in the chart? In the chart, next drug is our mepivacaine, intermediate acting amide, hepatic metabolism, no allergy, no power, nothing else. Never seen a single liner question on a separate question on mepivacaine. Pilocaine, intermediate acting, metabolized by liver, amide, no power, no allergy, methemoglobinemia, nothing else. Okay, Extra point, methemoglobinemia associated with it. Now, a very important local anesthetic, a combination local anesthetic, which we need to talk about, EMLA. We need to talk about what is EMLA. What is this EMLA? The full form of EMLA is eutetic mixture of local anesthetic. What do I mean by this eutetic? Eutetic means easily melted. It is mixture of two local anesthetic, lignocaine plus prilocaine in 1:1 ratio. Ligno and prilo in 1:1 ratio, right? The melting point of ligno and prilo individually is more than melting point of EMLA. So when we mix them, the melting point reduces. So it's easily melted local anesthetic. Guys, how do we give EMLA? We apply it on the skin surface, right? We apply it on the skin surface, right? We are talking about EMLA, in which we have lignocaine and prilocaine in 1:1 ka ratio. We apply it on the skin surface, it melts at the body temperature and penetrates 2 to 4 millimeter depth and produces a surface anesthesia of 2 to 4 millimeter depth. Superficial procedures like venous cannulation, etc. can be easily done under EMLA cream. There are a few things which we need to know about it. Ligno and prilo is present in equal ratio and equal concentration of 2.5% each. So concentration is 2.5% each. The ratio is 1:1. Guys, EMLA cream needs a contact period, a minimum contact period on the skin of 1 hour, and produces surface anesthesia of depth 5 to 6 millimeter, 5 to 6 millimeter, right? Maximum surface area where I can apply it, maximum surface area in any patient, maximum application 2000 centimeter square, not more than this. Maximum application 2000 centimeter square, not more than that. Okay, guys. Now, how do I apply EMLA? I clean the skin surface, inspect it. Any breach in skin continuity, we don't apply EMLA because it will get intravascularly absorbed. I don't apply EMLA in neonates because their liver and kidney is not mature to metabolize local anesthetic. Infant, it is very commonly used, but not in neonate. And we don't apply EMLA on mucous membrane. So, contraindication of EMLA, application. It's a cream which comes in a tube. So, we have to apply it on skin surface. Number 1, never given in neonate. Number 2, any breach in skin continuity. Skin continuity. Okay? Number 3, mucous membrane. Number 3 is mucous membrane. So these are 3 contraindication of EMLA cream. Got it, everyone? This is all about our EMLA cream. Coming on the next local anesthetic, again a very important one, bupivacaine. Now, what are the points of bupivacaine which we know? Long acting, amide, hepatic metabolism, right? No allergy, most cardiotoxic, right? Contraindicated for IVRA. All these points we have already discussed. For IVRA, it's contraindicated, right? All these points we have already discussed. Just one more extra point. I am writing repeatedly, it's most cardiotoxic, right? I am writing repeatedly, it is most cardiotoxic. But then also, if you see clinically, it is one of the commonest used local anesthetic. Why? And we have discussed the cardiotoxicity of LA is life-threatening. Because, why it is so commonly used? Because bupivacaine is best LA local anesthetic for differential block. Best local anesthetic for differential block. Got it? It demarcates between different nerve fibers very precisely, which no other drug does with such precision. Okay? At different concentration, it demarcates between sensory and motor fibers very precisely. So it's very good drug for differential block. So that's why it's very commonly used. What's good about BPVA? Good about BPVA. Good is it's best for differential block and it is long acting. We want to use long acting agents for regional block to produce a prolonged analgesia, etc. What's the problem of bupivacaine? The problem is it is very, very cardiotoxic, right? So guys, we want to take away the problem of bupiva and we want to maintain its good thing. So always there is a quest to prepare a better bupivacaine. So in that came a new drug called ropivacaine. Ropivacaine. What is this ropivacaine? It is S isomer of bupivacaine. See, bupivacaine is racemic mixture of S and R isomer. What was seen when the drug was studied? Problems was because of R isomer, work are because of S isomer. So S isomer was separated and ropivacaine was made, which is exactly bupiva, S isomer of bupiva, just differs in 3 points. Difference from bupivacaine. What is the difference from bupivacaine of this drug? Number 1, less motor block. Less motor block. It produces less motor block. Number 2, less cardiotoxicity. And number 3, less potency. Little bit potency reduced. Got it? This is the 3 difference of ropiva from bupiva. Otherwise, it is exactly bupiva. If bupiva is contraindicated for IVRA, ropiva is also contraindicated for IVRA. It is better than bupiva in safety profile, but not as good as lignocaine. Got my point? So this is all about ropivacaine, a better bupivacaine. Got it? Now, last local anesthetic is dibucaine. Nothing extra. Whatever is in the chart, we just have to go through that. And that is long-acting amide, hepatic metabolism, no PABA, no allergy. This is all we need to discuss about our local anesthetic. This is sufficient for solving the questions. Simple questions are asked about ropivacaine, about amla cream, little bit about bupivacaine, lignocaine, right? Which is ester, which is amide, difference of cocaine from rest of the local anesthetic, treatment of LAST, clinical features of LAST, which I will discuss more in central neuraxial blockade also. Then guys, systemic absorption of LA. These are the questions asked on our local anesthetic. So whatever we have discussed, this will solve more or less your 95% question. Okay.